Welcome everybody to our presentation, Finding the Magic in Co-Management. So we'll have a lot of material for you that we're excited to share. My name is Pierce Kenworthy, one of the optometrists here at Arizona College of Optometry.
And my name is Wendy Huang. I'm one of the ophthalmologists here. I'm a cornea specialist.
And I'm Robert Fintleman, the other ophthalmologist and cornea specialist. Oftentimes when you get sent a patient as a contact lens trial, we're just trying to figure out the scar or the irregularity, what's contributing more. Putting a contact lens on can isolate and remove the irregularity, so if the patient still sees poorly, the scar is more of a problem.
A lot of reasons that we're going to be discussing for a need for specialty lenses, how to evaluate those corneas. We have visually significant scars, injuries, other pathology like dystrophies that we'll discuss. Any kind of irregularity to that corneal surface is very likely going to wind up in your exam chair, and you're going to be working very closely with ophthalmology and optometry to make that patient see as well as possible.
So reasons for referral to a surgeon. Oftentimes you'll see progression of the disease, so that's a reason to send to one of us. New occurrence of pathology, seeing something new, and then also what would be considered a failed contact lens fit. That's a very generic term that a lot of people say, and we'll kind of go into how that's confusing for us in a second.
So make sure that if you say failed why. Mm-hmm. Problems with fit, where, is it something that we may be able to change, or the contact lens can't be modified anymore? And the most frustrating communication you probably have is if you don't know what you're talking about and you talk to somebody who is unconsciously competent, and then the one person who is unconsciously competent, meaning here, might not understand what you don't understand about how easy it is. Most commonly, you're probably going to be here and hopefully work your way to here, so you kind of know what you know and you know what you don't know.
But when it comes to contact lenses, I would assume that the most of ophthalmology is the unconscious incompetence. So please spell it out to us, because we really, really need to know.
That communication really goes a long way from the optometrist to the ophthalmologist, like we just heard from them. The different surgeons may have different expertise in certain areas, may not understand as much about certain contact lenses that you're fitting, and so as clear as you can be with communication, the better the outcome for everybody involved.
Like you said, different expertise. We have no expertise in
Yes.
contact lenses. None.
Zero. This is not something that is taught typically very well in most residencies and training for ophthalmology. So keep that in mind. Babes in the woods.
This is our impression of a contact lens. It doesn't matter what's underneath. Just put a lens on top. Everything will be fine.
Yes, you can fix everything, right, with your contact lens. So whatever I do to the cornea, you can fix. We know that's not correct. We'll go into that later, but that is the impression that we are given.
So the corneal shape becomes essential to understand when you're fitting a contact lens.
And whenever you look at corneal shapes, especially interpretation of corneal shapes, topography just makes a bunch of assumptions. All it is rings bounced off a surface, and it thinks that the cornea is more flat in the center and more steep in the periphery. And that's how you get elevation data from a topography. It is less affected by transparency because it's just reflections, but it is affected by the tear film. And obviously, higher irregular cornea will be more visible and more impactful on placido disc.
So any untreated dry eye can affect these readings. Just keep that in mind. Sometimes giving multiple readings before moving forward is really necessary. And
no limitations of your tools.
Which topographer has placido disc that they would be using?
So either the Zeiss Atlas, the Tomei oftentimes has it, the OPD3, the Medmont has them. But anything that you look at and you see rings is a placido disc topographer.
Nice. And I remember going camping with the Boy Scouts and all that fun and thinking about topographies of the elevation of mountains, and that's what we're looking at, is elevations and depressions on the surface of the cornea. And we have to look at that and say, is that normal? What areas are abnormal and why are they abnormal?
An interesting comment is here is like, you look at 3D and draw a map with rings and to represent it, and the other, basically topography is the other way around. You're looking at the rings and try to interpret that's what the map looks like.
So the corneal surface, we're going to go a little bit anatomical, start anterior, and look at some things that can impact the very front of the cornea.
And when I also like to think of examination, you go from the front to back. This is obviously a broad beam, thus you get a lot more scatter. However, when you look at this from the iris bouncing back, this is transparent, so the scar is not that bad. Very common finding in a graft with a running suture that you get some graft host haze and scarring. If it's too bad, that can be removed.
Where's that actually coming from, that haze? What's producing it?
It's literally deposits on top of Bowman, so very similar to a Salzmann's nodule.
Got it. More examples. This looks like a Salzmann nodule here in this example.
this outline. The arrow sign points directly to the pathology, more opaque than before. And here is another example of a different scar that's deeper, just because, again, whenever you look at a picture, make sure you understand what you're seeing. This is a very regular reflex, thus the anterior surface not very much affected. But you can see in this broad beam this kind of deep pattern of scarring, which is less likely to be Salzmann's.
So for anterior keratectomy, we usually use a blade or laser to remove the lesion. And then also, we can also supplement with mitomycin C to reduce scarring and improve healing. And sometimes we'll add an amniotic membrane to kind of help improve the surface healing as well.
And the reason why I particularly don't like using a laser always with Salzmann's is laser takes away the same amount everywhere. Salzmann's, as you know, is an elevation within the epithelium, so manually you kind of get down to a nice plane. We'll show it in a second. But if you did a laser removal of this, you would get the same irregular surface, just in a deeper layer.
And it's actually very nice because the Salzmann does have a natural plane, and you can actually, as we're going to show, peel it or puff it out, and it'll actually respect that line and come off nicely.
Is the term topo-guided laser relevant here at all? Is that something that would be helpful or not necessarily a relevance here?
Relevant, but not helpful. We're dealing with such a big difference in such a lot of tissue that a laser would not be able to target that effectively.
Got it. This is actually an in-office procedure not too long ago. This is what it might look like, a little bit of epithelial debridement around the area of the Salzmann nodule, and towards the end of this we'll see the actual removal of what looks kind of like a blister to me off the surface of the cornea.
Or callus, that's why I think of it. If you have it on the hand, that's what it looks like. Here it gets peeled off. The reason why I start so far up front is there's usually almost like a glacier effect where the actual nodule has an edge that's way further underneath the epithelium hiding, and you want to get that off to get a nice smooth area.
And that's that plane that we're trying to find when doing this.
Hoping for improvement in patients' vision, both with and without glasses, helping to normalize the actual corneal surface as well. A few more cases of Salzmann as well here.
Shared examples is a patient was sent in after LASIK years ago who had these very flat topography, irregular topography, was sent that contact lens should help, but the fitter had trouble getting a good fit, and we'll show in a second why that is. This kind of illustrates the Salzmann's nodule in the periphery, where you obviously will have some difficulty vaulting over, and you can see the modifications that have been made, but it's still not quite good enough either comfort-wise or vision-wise. Removal helps because it heals without complications, usually within a few days, less irritated because the dryness that happens from that irregular surface is now alleviated. Any Salzmann's, remember, an irregular surface, your tear breakup time is very, very short.
In this case, MMC was used. Dr. Huang, you mentioned some cases use MMC, some do not. Is there a pro or con for using that, and why?
So con, always risk with anything. Mitomycin C can affect people, can impair healing, in this case desired. But I tend to use it when I really want to make sure it doesn't come back, or if it's a recurrent one. PRK, post-PRK haze, for example, is almost always treated with mitomycin C. Salzmann's usually no. And this just helped. Now 2015, super happy, comfortable, and you can see the improved topography. If you remember before, and this was very irregular, and now you have more of evidence of previous refractive surgery, but that's it.
And this is why the communication is really great. So when fitting the contact lens, we might not know if you refer the patient back and say they've just failed, why. This is a very treatable issue. We could improve the surface so that the contact lens is better. So this is where an instance where the communication could be missed, but it's a really good opportunity to actually help this person.
One more Salzmann case, more recent actually, just had this patient in clinic, and I was intrigued because before doing anything, this is what their topography looked like, and you can appreciate on densitometry, which to me is a measure of transparency, how easily light passes through the cornea. You see where that white opaque area at the top is, that's where the Salzmann nodule was present. And this patient had it removed, and it looked beautiful 1 month post-op, but what intrigued me was a very interesting change to their refractive error, in that at first glance, I wondered, why did that happen?
So Salzmann, again, remember the normal shape of the cornea, you have more steepness in the periphery than the center. Salzmann tends to be additive, thus it flattens the center, thus after removal, they oftentimes get a myopic shift. And in this particular case, because the Salzmann was exactly in the same area as the previous with the rule of stigmatism, now you have more of the same.
So it's almost like taking the Salzmann, it got the cornea back to its more normal, higher amount of cylinder power, it sounds like. And I always am a little careful when I look at these scans, noting colors alone don't give you the whole story, because you'll notice on the scan before, 48 is the bright yellow. On the other one, 47 is the bright yellow. So color's not going to tell you everything. It's the numbers also very important to look at.
And
Pay attention to scale.
Yes, and the relative versus absolute. The relative scale changes to try and encompass the whole pathology. Here you can see the scale is much, much less, 53 to 38, as opposed to beforehand, it was 30 to 60.
Mm-hmm. Similar, I think, to Salzmann nodule, but a lot of patients present with EBMD, and this is a video of anterior keratectomy, similar to what we saw with Salzmann, but removing that superficial epithelium.
And here you can see some of the irregularity on Bowman's. And interesting enough, even though the irregularity is a minor problem, this, if it's central, it can affect your best corrected visual acuity, even with a contact lens, because it's quite not as clear and you get some impurities there. You also probably know contact lenses improve some higher order ratios, but not all. They reduce them overall. A normal epithelium should not come off as easily as this. This is just wiping it away pretty much. This was me polishing it with and wetting it before using a diamond burr. This is kind of our way of doing things. It's a rotary tool and a broad-based diamond burr that just creates a little bit of scarring between the Bowman's membrane and the epithelium so EBMD doesn't come back.
And moving on to a different condition, Terrien's marginal degeneration, a thinning normally of the superior cornea in some cases.
And in this area, make sure, again, all four maps make sense, right? So you have this particular area that is distorted, and the same area see pathology on elevation front, elevation back, and the thickness map. Terrien's, there's thinning and kind of almost, again, an elevation bulging out. To treat this with a full thickness transplant is difficult because it would require a very large graft or a very centric graft. So what I chose to do in this particular case is add tissue in that same area, manually sliding. This is new tissue, and as you can see, it's thickened quite a lot, as you can also see on the topography. There's more tissue available, and contact lens, again, was not quite necessary, but would have improved his vision even further.
If I might sneak in on a question about that topography there, you mentioned bulge of the superior cornea. When I hear that, I expect to see a bright red area right at the top. Why does it look more like wings getting pulled up to the top? And to me, it looks like a flat blue area at the top.
So two reasons. One, topography is based on, as I mentioned before, a lot of assumptions, and centration is important. So the further peripheral your eccentric or area, thin area goes, the more it looks like the crab claw, the kissing doves, I think was the other description. But that's, as you know, not a pathognomonic sign for example, pellucid. And the flattening, going back, this is supposed to be steeper, right, overall. So if you have an area that bulges up in the very periphery, now the central, relative to before, is flatter than it's supposed to be.
Thank you. I think that's a very important distinction there. We saw this already, and then this is what the patient looked like 3 years later. Looking very stable, that patch graft is holding in place, and the patient's doing very well at this point.
The question was, why am I coming back?
Yeah, so it's a good sign. They don't feel like they need to come back.
Why am I here?
And I like looking at before and after, that direct change on topography and anterior segment OCT. Oh, pterygiums, we see them all the time, especially here in Arizona. The sun beats down on us all the time, and this can impact the topography as well.
And here, again, you see flattening nasally in the same area as you see the pterygium, with an elevation in the front. I'll explain this in a second, and a thickened pachymetry. So all these four maps make sense. And the reason why this makes sense, even though it says minus, is because any elevation in the front pulls, in quote, the best fit sphere a little bit more anteriorly. So now relatively, you have a negative area in that same spot, even though technically it doesn't affect the posterior surface at all.
Can one of you humor me with a very simple explanation of the best fit sphere? I hear it all the time. It comes out of our mouths quickly. What does that mean?
The best thing is if you think of any irregular, any kind of up and down. If you want the stock market, for example, they draw lines through the stock market. It's like, oh, it's nice and upward. But if you look more detailed, you see lots of ups and downs. Same thing here. The lots of ups and downs are smoothed out, and compared to the best average, what does the exact area look like in that particular area? So you draw an average of everything, find the best shape that on average fits it, and then look in each spot, well, how's that different to my average?
So it's all relative
Yes.
to this best fit.
Got it. This is a recent pterygium removal, so in many cases, if it's growing quickly or bothering the patient, inducing astigmatism, a lot of reasons to remove a pterygium, and this is the dissection away from Tenon's capsule and continuing on with the surgery.
And we think that most pterygium problem is in Tenon's, not conjunctiva, so try to limit the removal of conjunctiva. This is now the actual treatment of the cornea, where it's removed and peeled off, this tends to, again, most of the time, leave a fairly smooth area. There's always going to be scar, but there's no need to kind of dissect that with a blade. Superior graft is harvested, removed, and then at least most, not a lot, but most people will just use glue to keep it in place, thus securing it without sutures, and that tends to heal. Final appearance is probably 6 to 8 weeks, but there's a fast recovery within the first week until the epithelium is closed, and then a few more weeks until the actual appearance looks how you want it to.
And there is varying technique in doing this removal. Some people do use amniotic membrane, so it may look a little bit different afterwards.
Sticking to the anterior surface, we know that limbal stem cells are crucial for regenerating corneal epithelium. When those limbal stem cells become deficient from a variety of reasons, we see problems. And sometimes it might even be a contact lens that could contribute to that problem. Is that correct?
Contact lenses both cause and are used in the treatment of limbal stem cell deficiency. The other etiologies you see here, inherited or tumors, obviously, if it's injured by surgery, chronic medication. So again, contact lens, but the treatments can also involve a scleral lens, especially. There's a pretty significant incidence in soft contact lens wearers, and the overall 15% of limbal stem cell deficiency is attributed to contact lens wear. The brief reason why contact lenses can cause the limbal stem cell deficiency, because all these causes, mechanical trauma, dryness, lens solution, and hypoxia, are part of contact lenses. Especially underneath the upper lid, you have the mechanical trauma of the lid beating on the upper cornea. You have decreased oxygen because of the lens and the lid. You have lens solutions, and dryness increases friction, thus you get even more trauma. The presentation tends to be, if a contact is related, it's most commonly superiorly, and oftentimes you hear statements like, oh, there's dryness on the top. There shouldn't be any dryness. Why? Because it's covered and there's a contact lens on. Flowing epithelium is the most common early sign, which is kind of these strands that go down. Delayed staining, meaning you put in stain, don't really see anything. You come back, it's like, I don't remember anything being there. And recurrent erosions plus a little bit of haze. Vision tends to start to get blurry once the limbal stem cell deficiency reaches the visual axis.
So really checking underneath a lid, I think that's easily missed, and then kind of looking in detail at the epithelium adjacent to any pannus that is formed is kind of the target area that you want to try and focus on, and just that flow, looking for that flow to find early limbal stem cell deficiency.
If you see it, and I was going to mention also, sometimes we look at that and say, oh, that's SLK. This is a thyroid patient with hyperthyroidism, and they have superior limbic keratoconjunctivitis, but there's no reason you couldn't have SLK that's contributing to limbal stem cell deficiency as well.
Two quick thoughts there as well. Partially that is actually the superior limbus is inflamed, thus it's not working as well, thus you get epithelial dysfunction. But banished contact lens is one of the treatments for supralimbial keratitis, and thus it wouldn't make sense with contact lens. But important, you should always look at every contact lens patient without their contact lens on, and obviously look underneath their lids and ideally flip their lids because you'll see a lot of things. Staining helps. If you use lissamine green, you might see something with SLK, not with limbal stem cell deficiency.
We have the comment, move the pathology. What does that mean?
So if the problem is from, and you'll see this in a second, there's a case, if the vision is affected by limbal stem cell deficiency because it's in the center, we can move that bad epithelium out of the way.
Nice.
So in this case, the good epithelium is this, the non-staining part, this is all bad epithelium. And you can tell it's somewhat in the visual axis. If this was all the way across, patient wouldn't notice.
And this is the irregular kind of roll pattern that you can see with limbal stem cell deficiency. So you'll kind of see a patchiness when you're looking, especially in the area of pannus, as I mentioned.
So again, debridement, remember this epithelium is very, 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 very sensitive to any touch. So you touch it with we use we call them spear sponges, but little triangular sponges. Even if you touch the epithelium, it goes away immediately.
Very fragile.
Normal epithelium does not behave that way. And after healing, as you can tell now, I moved the pathology from the center pupil to now outside the pupil. Vision was much better afterwards. Still not great, but improved over before.
Nice. Another example here, patient who had LASIK, glaucoma as well, been having decreased vision for about 2 years, shows up with 20/80 vision on presentation. This looks actually very similar to the other patient, very similar pattern to what we just saw.
And yeah, same treatment.
Challenge will be exposure to drops. Explain that, one of you, please.
So if you think that the limbus stem cell deficiency is due to chronic glaucoma use, drop use, obviously the patient will still need to be on glaucoma drops after the treatment. So if that's the cause, how do you remove the cause? And one treatment would obviously be SLT or another laser, which again, cooperation or communication with the surgeon is important. So you could say, hey, they're on glaucoma drops. Is there any way to get rid of them?
And one more case, 52 years old, patient with decreasing vision with scleral lenses in both eyes.
And this is again that pattern, that flowing epithelium right in the center that you can see that is limbus stem
Right
cell
in the
deficiency.
center of the vision, right there.
And here's a particular case where I said contact lenses can be used in the treatment of limbus stem cell deficiency. I should have added properly fit scleral lenses because this particular patient had a poorly fit contact lens, which actually caused them to develop limbus stem cell deficiency from a poor scleral lens fit. And again, this is more the staining pattern. I just want to point out again this flowing epithelium and still sided superior limbus, most sensitive and most affected area because of what we pointed out beforehand. And she developed recurrent corneal abrasions after years of scleral wear, which again, technically you should not have. You have protection, your epithelium should be great, your dryness should be great, but patient can have multiple problems that can affect them in the long run as well.
We've used the term flowing epithelium a few times. Now, if I was to do a map and check the corneal thickness, the epithelial thickness map on this patient, would it be thicker or would it be a normal thickness but just not be attaching to the deeper tissue, or both?
Yes. Abnormal, tends to be thicker, but again, it's like hard to interpret because at some point assumptions are made by the epithelial thickness map as well, and the ones that we used to use at that point in time are not as good as what we have now. So I don't know yet is the honest answer.
And these are visually significant. I mean, we're showing you a lot of stain in the eye, and it's pretty obvious when you're looking at these pictures. But initially, when you're examining a patient without any stain, it can look a little bit like dry eye, just something very simple. So it's really important to kind of make sure that you're really staining the patient and really kind of acknowledging how visually significant this kind of interface can be, because what you have to keep in mind is we're used to seeing something completely homogeneous, and to look through that edge is visually significant.
So we did change the scleral fit, started topical steroids, and she did not want anything done to her surface. Otherwise, again, I would have tried to move to pathology. But the treatments of this, to remind you, is remove the pathology, decrease inflammation, increase lubrication, and protect.
So summarizing a little bit of the ocular surface, we become somewhat of detectives when we're looking at the cornea. We're looking at the staining pattern, we're looking at their history, how is the contact lens fitting on the eye, where is the cornea affected, what's helping it get better, and we really have to put our detective hat on a little bit and really analyze that cornea for what it is.
And what's challenging in the limbus stem cell deficiency is it's caused by the contact lens, but now they're uncomfortable without a contact lens and they see better with the contact lens. So you have a patient with a problem caused by a contact lens that sees better with a contact lens. I'm basically talking soft contact lens here. But patterns, very important. I want to say that again, because one of my pet peeves is when somebody presents a patient and asks them what do they see, and they say, I see dryness. Which reminds me of the movie I See Dead People. But anyway, it's hard to see dryness. If you ever see dryness, please tell me, because I would be curious. You see signs of dryness, but please describe the staining pattern. That will tell you a lot, and it will tell you preceptor a lot what's going on. And that's, as you know now from contact lenses, also very important. Where does it stain? How does it stain?